From Pand Health, I'm Rachel Wexler. Welcome to our show, The Mind Exposed. Every month, we bring to you national experts to explore mental illness and mental wellness. We hope you enjoy this month's episode.
Hello and welcome to today's episode. My name is Kyle Menchel, lead clinician at Pand Health, and with me today is Pand Health's medical director, Dr. Eric Wexler. Today we're going to be speaking about the social impact and importance in psychosis. So, thanks for joining me.
Thank you for having this interview.
So, social skills, social deficits, social cognition. There's a lot of terms when it comes to psychosis and psychosis treatment that have to do with one's ability to socialize. And in my experience working with the families of individuals who have various, thought disorders, they can get confused with that. So just before we even launch into why it's so important to engage the modalities we do engage and to target these deficits that we do target, what are these terms? What is a social skill versus a social cognitive skill,
So the terms do get confusing. But before I explain, let me just step one,
Absolutely.
maybe 3 steps back.
Sure.
Why are people in treatment? Because they want better lives. They want purpose in their life. They want meaning. They want maybe fulfillment. They want stuff. And one of the most important things that gives our life meaning is the connections we make. The activities we do, often with other people, the friends we have, the connections we make, the family we maintain and rely on, all of these are because humans are social. Now, unfortunately, one of the things that psychosis does is it robs people of a lot of the fundamental machinery that allows you to socialize normally. Now, we're having a conversation now in English, but a million years ago, we didn't have language. But people communicated, animals communicate. A lot of evolution was devoted to making our brains very adept at communication, even before there was language.
Wow.
And so non-verbal, through tones of voice, because we had speech, the tone of our voice, the expressions on our face, especially our eyes and our mouths, these conveyed information before. And so there are entire separate brain circuits that are older that are devoted towards a lot of this non-verbal communication. How we feel emotionally. That is another thing that we possessed way before we've all had pets who are sad or happy. People have emotions outside of their language, outside of their ability to express it. And one of the things psychosis does is at each of those aspects of what we call social cognition, things I described, are in deficit. So people will look at someone's face and may not be able to tell if they're happy or sad. Makes it very hard to have a conversation when you don't know if the other person is mad or bored.
I can imagine.
But also, you need to identify what an emotion is. You need to identify it in yourself to express it, but you need to identify it in others to know how they're going to react, because you need to predict. If you're going to make decisions, you need to anticipate what's going to happen. And that's sort of the final the aspects are understanding what is the person thinking based on either the nonverbal or even what they say. So a common example of what we call theory of mind or mentalizing is that ability to read between the lines. If you and I were going to a conference on a business trip, and we drive up to San Francisco, like where the APA was this year, and after 6-7 hours, we get to the hotel, and you say, let's go over our presentation tomorrow, and I say, hey, Kyle, it was a long drive. Am I really trying to communicate the length of the drive? No.
No.
It's clear that I'm trying to say, I'm tired, leave me alone. But that requires understanding what the person means, not what the person is saying. That theory of mind. And that translates into also, do they have hostility or ambivalence or compassion. Like, what are they feeling? Because that's going to cloud or influence the thought. So these are all social cognition, and it doesn't take a lot of thinking to realize that if those things don't work, you are going to have a lot of trouble maintaining relationships or forming relationships.
I can imagine. And is this something that you see in your experience working with this population frequently? Difficulty with relationships, so on?
Absolutely. And what's important to realize is that what we call psychosis originally was characterized because it was cognitively impairing in general. People think slower. But then, even before people started attaching significance to hallucinations or delusions, they attached the word autism, meaning to look inwards, and the fact that people stopped being able to process interactions with people in the outside world. Now, what autism meant 100 years ago versus what it means now, that's an entirely different discussion. But it's the same idea, is that people appeared what we would call autistic because at its heart, that autism, that inward direction and focus, is really an absence of ability to process both emotional states and nonverbal communication. They lack social, they have impairments of social cognition. And what's important to recognize is if you look at predictors of people's ability to have jobs, have families, function in life, have quality of life, enjoyment in life, it's far more determined by their social cognitive deficits than the presence of whether they hear voices or have bizarre beliefs.
So, and that, unfortunately, is the most common or famous, if you will, symptomology associated with things like schizophrenia, right? The hallucinations, the beliefs.
Absolutely.
And what you're sharing is really, it's the ability to have these types of interactions and develop social relationships, because that's important in every area of life requires social engagement.
Absolutely. And what you bring.
My question for you, though, based just quickly moving off this autism thing, is fascinating. How does one tell the difference? You know, is what is going on related to autism, or is this different when it's related to psychosis?
There are differences. That is a very nuanced discussion, a little more probably than for today.
Understood.
But the biggest distinction is, or at least the easiest in most cases, is the onset. Autism is a developmental disorder. You must have an onset in childhood. Schizophrenia is a disorder that comes on in late adolescence to early adulthood. So if the social cognitive deficits weren't there when the person was 16 or 15 or even 14, that is a primary psychotic disorder. Now, turns out that people with autism can have both. They can develop schizophrenia later, and they do so at a higher rate. But these social cognitive deficits are pretty defining, and sometimes making the distinction between the two doesn't actually change how you treat them. And so it may be intellectually satisfying sometimes, but for at least the first steps in treatment, you may approach them in the same way.
It seems to be a theme in a number of these discussions that are having throughout this podcast series, is that the distinctions between diagnoses really are not that important from a clinical lens, in the sense that when doing behavioral interventions, if you're targeting social cognitive deficit, you're doing that the same, right? Whether it is someone who is experiencing autism or someone who is experiencing schizophrenia. Is that correct to say? Now, you're a psychiatrist. From a psychiatric lens, maybe it's a bit different, but behaviorally, psychotherapeutically, what would you do to support somebody?
So I would say that they're not psychiatric, psychotherapy, behavior, whatever.
Yeah?
One brain.
One brain. Fair, one brain.
So one brain. And now, the medical side, sometimes people have referred to as the medication side. Medication's great at hallucinations, delusions, much less for improving social cognition or improving motivation. And that's where behavioral interventions come. In the behavioral side of things, what we call sometimes the psychosocial interventions, there are subtle differences because you do need to still work with the whole person. What are their motivations? Because someone has to want to get better to get better.
That is true, yeah.
But if you leave all those things aside, if someone lacks the ability to know whether a face is happy or sad, it kind of doesn't matter why. And we have different treatments for different aspects of why they are, and forgive the term, social failures.
Okay.
And so it's, now I say forgive me because they have simply failed. But when you think about it, everyone who's ever succeeded at anything was a failure right up until the point they succeeded. So one of the important things maybe there on a tangent is it's important for people to understand that repeated failure doesn't make them a failure as a person. So we have to work with the motivation. But the skills part of it are, there's a lot of different things you can do.
And so, I know that at PAND we employ a number of modalities that target exactly this deficit that you're referring to. But, for those who are unfamiliar, what really are the modalities that are going to target this specific, social cognitive deficit, if you will?
Right. And so I think you have to look at social cognitive deficits just like you would treating any illness that has disability associated with it. Part of it is you want people to use what assets they have to recover as much functionality. You then want them to learn how to compensate for what is no longer working mechanically. And third, you want, if you can, give them something new abilities or improved abilities that will make it easier for people to recover functionality or compensate. And so you talk about rehabilitation, getting back functionality. You talk about this overlapping concept of remediation, where you improve baseline abilities, and then you compensate for that which remediation has not improved. So, for example, maybe some other things are a little bit easier to adjust to that. Imagine someone has a head injury, and they are thinking more slowly, and they have trouble concentrating.
Okay.
Well, the remediation could be, you could give them a medication like a stimulant, which would help them concentrate better or think faster. That's a form of remediation through medication. You could teach them, or rather give them practice exercises so they can practice different mental activities so they get faster at them, because we all know that we get better at anything we practice. That's what we call cognitive remediation, or we do it by computerized cognitive remediation. And then you can teach them skills. Well, if you can't remember it, write a list. That's the simplest form of cognitive compensation.
Yeah, we do a lot of calendar keeping, note taking, etc.
And so those are sort of in the cognitive realm, something that maybe is a little bit more accessible to people, how one applies the rehabilitation, remediation, and compensation strategy. But the ultimate goal is to be more functional through whatever means. And so we do all of those, but on a social level too. We have what are called social skills training sessions.
Yeah.
So social skills training has been a sort of mainstay of treatment in schizophrenia and autism. And in fact, it traces its roots back to work started in the 70s, kind of down the block at UCLA.
It's been around. Oh, down the block.
So it was recognized that psychosocial rehabilitation starts with social skills training. And it's important to recognize that people have known for decades medications are not the end-all. They're not sufficient. There are other means of treatment. But this knowledge is perpetually lost and not disseminated to the public and not available most of the time. And so the ideas are not new, they're just not available. And so that was part of the impetus actually behind starting
Interesting.
Hand Health and our California on Track program, was to roll out skills that were and programs that were developed either locally at UCLA where I used to work or at other institutions around the country. Now, the next step, so social skills is where you simply practice.
Yeah.
You simply do it. You like if you hurt your arm and you're a tennis player, you rehab the arm. You keep working it out.
They could do a lot of making requests of people.
Yeah.
How do you start a conversation? How do you end one?
So those are common social skills,
Yeah.
and how do you do those? Then we do have compensatory strategies. So if you don't know really what the person is thinking, well, don't jump in, wait.
Mm-hmm.
So don't jump to a conclusion. So one of the problems that our patients have a lot is they jump to conclusions, and it's hard for them to give that up. Those are cognitive biases. And we have programs that address that. It's called metacognitive training for psychosis. There are other programs we do where we teach people to just look at other aspects of body language in a more formal way.
Okay, like
in order to compensate if they can't read the face.
So like a more systematized way, a very rigid
Yes.
way of looking at faces.
Yes, definitely rigid, definitely
Okay.
in a systematic one that can be formulaic, algorithmic.
Okay.
And then
that's beneficial for folks in this population, being able to follow these step by step.
yes, and because just like people with autism, very often there is a mental rigidity there that likes that type of organization, that makes it easier to comprehend. It's more concrete.
Yeah, and so rather than try to change that style of organizing, it's like, why not just lean into it and provide these very
We
helpful
definitely,
ones?
it's like a lot of things. You need to accept what hasn't changed while you remain ever vigilant to try and make improvements.
Okay, yeah,
You don't get
because we're also
complacent.
still supporting abstract thinking.
Yes.
Right? We're trying to do both simultaneously.
Yes, absolutely. Because you got to work with. You want to get somewhere, but you can't get there by bypassing what you got.
Yeah, that
Like
makes
you
sense.
got to work with what you got.
Yeah.
And then like the last thing is where there is a separate type of training which is not available actually anywhere else on the West Coast, but called social cognition interaction training.
Yeah.
And it's a form of remediation where we approach, as you know, different aspects of social cognition
Yeah.
in order to actually change the way people process some of the nonverbal information.
I mean, as you're familiar with, I'm a huge fan of what we call SCIT. Arguably my favorite group to run in all of the California On Track program. And the impact that I see from the clients is maybe not immediate, but it is clear as day in a couple weeks of doing it. And I just find that so exciting. For this, though, I'm going to play a little ignorant, right? You mentioned it targets these different kind of domains of social cognition. Like, can you say a little more about that? What is it actually targeting?
So, don't want to get too jargony. Okay, but you just using some of the terms that we used before. Just we'll focus on theory of mind.
Okay.
And how people read into the emotional content.
Okay.
Sort of like, what is their bias? Are they angry or mad or
So this
sad?
is the face stuff you were talking about
So
earlier.
it's a but you have to know, like, it's a combination. We all process everything at the same time. And for some of us, you'll have a person who is being really nice and smiling, and they're really angry at you because of the now.
Okay, that's like context.
Yeah. So
yeah.
the idea that real normal conversations require you making judgments about stepping away from just the words and looking for other clues and trying to infer the mental state and the emotional state of the person you're talking to. So it's a little hard without like sort of visuals, because a lot of this is done visually.
In what sense?
So you just think of the testing. Like you can't even know what someone does if you can't. It's hard to say someone this is a happy face, this is a sad face. You should be able to recognize the difference if you don't show them a face.
Okay, so it's part of this. You're showing all these different faces.
Yeah, and so, but something you brought up, which is, I'm going to turn the tables here.
Okay, go ahead.
Okay, and so, as you all know, there are three main components to SCIT. Which of the three do you think the clients or patients sort of appreciate the value in most?
Ooh, in my anecdotal experience, I have found that the attribution piece they tend to respond most to, or they feel like they're interested in
What we call attributional bias.
Attributional bias, yes, I realize we didn't even touch on that part,
Yes,
which
sir.
is kind of this idea of why do things happen, right? Like, I hear a thump from the other side of this wall. Is my immediate assumption, oh, a robber has broken in, and now I'm committed to that belief, and I will fight tooth and nail against anyone who's going to say otherwise, or am I open to there being others? And I know that's where the metacognitive training that you talked about also touches a little bit on that.
So there actually are overlaps.
Yeah.
So as the person who actually is interacting and doing these groups, do you find that the clients are able to recognize how the two overlap and how
Yes.
they are complementary to each other?
Yes, especially with some of the more seasoned clients. Yes, I have noticed that they also respond best to both of those pieces, because I think the repetition of a lot of these practices just ingrains it a little bit better. Or maybe I'm projecting my own just guesses onto them, but I think that seems to be the case. I have noticed when we get I show all these faces, right?
Yeah.
A lot of the clients are just like, why are we doing this? Even though they're not necessarily correct. I'm like, well, because the reason we're doing this is because you just looked at a picture of someone smiling on their wedding day, and you told me that they were being sinister, which is a very real example that I had a few years ago when I was doing
Which
this.
is actually also part and parcel of the illness, is that one of the things in psychosis, as people lose some of these social cognitive abilities, they actually develop an adverse attributional bias. It is most common for them to believe ill or intent to harm. So they actually are
Interesting.
So they're actually not neutral. They actually adopt both a potential harm, malevolence to attribution.
Does that have to do with like just a heightened state of vigilance, or?
You know what? There's a lot of reasons why one can imagine it. It's not it's not the same as, but it's also not uncommon that when people are losing their hearing and they don't hear and they don't catch things and they misperceive, they start acting very paranoid. Even without cognitive impairment. Is that our attribution is largely based on how we've been treated before. The dog that's been beat too much is going to always think that the next person's going to beat them. So we are influenced by our experience. In the absence of experience, the brain fills in with something else because there has to always be a default. It's just the way our brains work. And it happens that maybe it's evolutionary that it's better to assume harm than benevolence. Now, that's a evolutionary psychology explanation,
sense.
but it passes the laugh test for sure. So there's a third part of SCIT 2.
Yes, there is. And that's actually my favorite part. But I have found that the clients sometimes respond
So
well
what
to
is
this.
your favorite part then?
My favorite part is theory of mind. Yeah, I would say the theory of mind, the ability to, like you had made the example earlier.
And there's a third part too. There's theory of mind, attributional bias,
and emotion recognition. Goes back to the faces. Yeah.
And so, do the clients actually recognize that they don't get the emotion stuff right?
Not
and do they think any of
always.
it's important?
No, not always, honestly. That doesn't mean they don't get a benefit from it, though. I have, even though they might say, why are we doing this again? Their scores go up during the course of doing it. But, that one more than the others, when like I give the example of a thump across the room, And then it turns out, no, it was the cat moving and the cat knocked down a vase. Most of the clients, some don't, but most do, go, oh, okay, I guess I was wrong. But when it comes to the face, going back to it's a photo of a wedding day. She's smiling big. She's in a gown. That person is sinister. And I go, no, actually, let's look at, and we do this thing where we draw a triangle on their face to really highlight the parts of the face, the eyebrows, the cheekbones, the corners of the lips, that really identify and create a very, as you're saying earlier, like this kind of systematic way of looking at it. And we do that. All of the cues are the corners of the mouth up? Yes, they are. How are the eyebrows? This is a happy person. So, are they happy? No, I still think they're probably sinister. Oh, okay.
Or I agree that
yeah. That one I have found, that one takes the most repetition.
Right, but it can get better.
It absolutely does get better. And without necessarily the insight getting better. Is that something you've noticed throughout this?
Well, of course. And it's very important thing for especially families to recognize is you can do better without understanding necessarily why you were doing badly in the first place. That insight isn't always required, and honestly, the mere acceptance that life could be better is kind of all that you often need.
So you don't ever need to recognize that, I went through a period of my life where I really struggled to read faces. You don't need to recognize that to get better from that.
You don't need to even to understand that you had a problem, because most of our patients have what we call, this big fancy word, anosognosia, meaning they have a blindness to deficits. And they just can't accept that they have anything wrong with them. Yet at the same time, they can process that their life is not where they want it to be. And they have concrete goals. I want a girlfriend.
I want a job. I want to live on my own. And then that's really all you need to get your foot in the door, huh?
Right. Yeah. I think that is among the biggest things.
I think so too. Yeah. Well, and with that, thank you for stopping by and listening to the podcast. Dr. Wexler, our medical director here at Penn Health, thank you so much for coming in. Any final words for our listeners before signing off?
The only thing I always say is that hope. It's one word, but it's what keeps everyone going, because everyone, no matter how bad the situation is, can get better. Don't give up and don't fall victim to low expectations. That's what you need.
Thank you for joining Penn Health's The Mind Exposed. You can watch us on YouTube or listen to us on Spotify or anywhere you get your podcasts. See you next time.